Okay, now we get to go on to the good part, on to oral presentations. Honourable members, at our February 17th, 2022 meeting, the committee agreed to invite additional stakeholders presentation in relation to the matters referred to us by the Legislative Assembly. Our first presenter today is Dr. João Goulão. I apologize if I got that wrong. The Drugs and Alcohol National Coordinator in Portugal and Director General of the Intervention on Addictive Behaviors and Dependencies General Directorate. Dr. Goulão, thank you so much for your time today and for joining us. Please proceed with your presentation. Oh, do we got you? There we go.
Good morning. Good morning to all. Thank you, Mr. Chair, for this kind presentation. I am very happy to join you in this discussion, even if I am not an expert on safe supply, because we do not have the experience. Anyway, here in Portugal, we faced a similar situation to the one you are now dealing with a huge number of overdoses deaths, huge problems related to mostly to heroin, some 2 decades ago. And I would like to share with you some views about how we dealt with those problems and make myself available for any queries that you might have. If you allow me, I will share my screen to share a presentation. Okay, it's there. Now, as I said, we faced a catastrophic situation back in the 80s and the 90s in Portugal, mostly related to heroin. And what I want to share with you is the way that we dealt with those problems. By the end of the 90s, drugs and drug addiction were the main concern of the Portuguese population. And we have 1% at least of the population affected by drugs problems. That means 100,000 problematic users, 98% of which were heroin users, 48% of them using the IV route. They contributed on 56% for the new HIV infections that happened in the country. We had around 350 overdoses deaths a year. And the response that was organized by our state was a new strategy that was approved in 1999, a new paradigm, the Law 30 of 2000, the law of decriminalization, probably the most known aspect of our policy. The creation of a national coordination. National coordination means coordination between different ministries that have something to do with the drugs problem. The creation of a national network of structures for intervention, building what we call the integrated model with a very close cooperation between the several components of the responses. The first Portuguese national strategy had two main components, the supply reduction part and the demand reduction, both based on the principles of humanism and pragmatism, and the traditional components of the demand reduction side were harm reduction, treatment, prevention, social reintegration. But on top of this, and assuming that we were dealing with health and social condition rather than a criminal one, the proposal was in the sense of decriminalization of every drug. We call to this and the bridge between the supply and demand side, we call the integrated approach, and evaluation is a crucial part of all the system. Starting with the dissuasion model, the subject of decriminalization, I would like to say that the law 30 of 2000, the law of decriminalization, only changed one article of the drugs law of 93, a law that still stands mostly, and the article that was changed is the one that refers to personal use and possession for use. And it says the consumption, acquisition, and possession for own consumption of plants, substances, or preparations constitute an administrative offense. Possession cannot exceed the quantity previewed for individual use for a 10-day period. Exceeding this quantity, criminal procedures take place. So this means that the drug user is considered as a person in need of health and social care. This dissuasion intervention provides an opportunity for an early, specific, and integrated interface with drug users. So we consider it as an indicate prevention tool. And it is aimed and targeted to the drug user's characteristics and the individual needs. It's important to stress that in Portugal, the use of drugs is still forbidden. However, and unlike models from other countries, where drug courts were created with streamlined procedures under the Ministry of Justice, the commissions for the dissuasion of drug addiction privilege the health approach. They are bodies under the custody of the Ministry of Health. Of course, it only works if a coordination between services is present. All the services who may have any kind of responsibilities in this area, from employment and training services, addiction treatment centers, health centers, welfare services, prisons, and so on, schools, police authorities. So there's a network that is needed to make this system work. As I said, using drugs is still forbidden. And there's a long list of administrative sanctions that may be applied to people who use drugs or people caught in possession of drugs. However, never happens to have a criminal record who had clear benefits in the stigma and allowing people to recover a normal life. The criminal record is usually something that impedes people to access credit, to get a job. There's a lot of difficulties that occur as a consequence of having a criminal record. It's as this list is a long one with many possibilities of administrative sanctions, it is possible to define sanctions according with the personal lifestyle and conditions. I would like to note that monetary fee is never applied to addicted persons. Just briefly, I would like to show some outputs of this system. From 2001 to 2020, we had around 150,000 offenders, from which 82,000 were assessed as non-problematic drug users, occasional recreational users, even though after the interaction with the health professionals, it was possible to refer them most of them, 44,000, for specialized support, such as health support for other subjects or for social or psychological support, in any case, from the 15,000 problematic drug users that were assessed. 12,000 were accepted to be referred to treatment centers, treatment teams, and almost 10,000 actually initiated treatment in the centers of integrated responses. So it's a supplementary gateway for the system of treatment or to indicate prevention related to substances. In the beginning, when this law was approved, we faced some difficulties with the United Nations bodies. And it took some years until it was recognized that it was a good move. However, in 2016 at the UNGAS in New York, the president of the International Narcotics Control Board, the guardian of the treaties, stated that the Portuguese approach is a model of best practices fully committed to the principles of the drug control conventions, putting health and welfare in the center, applying a balanced, comprehensive and integrated approach, and based on the principle of proportionality and the respect for human rights. So since then, we feel much more comfortable with our approach, and somehow we open the space for other countries to follow the same via if they wish. Our policy is based on five pillars: dissuasion, and they anchor all the others: prevention, harm reduction, reintegration, and treatment. We have a quite solid network, public network of services for treatment that is complemented by regulated NGO and private responses. We have a high range of different models for intervention, but they are complementary and they allow a choice between the models to be followed or to be addressed by the clients and by the professionals. Along with this, we developed a set of strategies and programs in terms of harm reduction, from low threshold methadone administration to opioid substitution therapy and other dependence treatments, naloxone distribution, needle and syringe exchange programs, counseling, diagnosis and referral to treatment of drug addiction and of other physical diseases, information, education and communication at the street level, using peer education in the party scene, for instance. Recently, we started the installation of safer use sites. We develop policies inside detention settings, prisons or youngsters detention sites. And we are developing recently as well the policy related to drug checking to assess what actually circulates on the street. I would like to take this opportunity to share with you those are some of the structures: street teams, refuges and shelters, contact and information points, drop-in centers, mobile outreach teams for the prevention of infectious diseases, cabinets of psychosocial support, and, as I said, supervised drug consumption sites. With this, we had some important results that I would like to briefly share with you. One of them this relates to the evolution of HIV infection that was really catastrophic in the mid-90s. This is the line of new HIV infections among people who use drugs. But since 2003, 2004, it dropped under the level of new infections among heterosexuals or homo or bisexuals. Nowadays, it's the contingent that is less represented in the new HIV infections in our country. On the other side, we have, as I said, by the 90s, the late 90s, we used to have around 350 overdoses deaths a year. Nowadays, and here in this graph, we have since 2013, 22 overdoses, 2014, 33, 2019, 63. There's an increase in the last years. We are trying to work on it, but in any case, we have the lowest number of overdoses deaths among the European countries. The new users that seek for treatment in the ambulatory public network have evolved like this. In 2011, we had 51% of heroin users. It dropped to 16% in 2019. Cocaine has been more or less stable from 15 in 2019, 26%. There's a slow increase in figures of cocaine. And nowadays, the highest number of new treatment demands relates to cannabis users. As you can see, new psychoactive substances or all the others remain in very low levels, around 5% of new treatment demands. Comparing with the situation in 1998. As I said, we had 1% of the population affected by drugs problems. Nowadays, we estimate that we may have 0.33% of the population. From the 100,000 problematic users, we estimate we may have 33,000 problematic users nowadays. From the heroin users, 98% in 98, we estimate nowadays we have 16% of all drug users using heroin. From the 48% using the IV route, nowadays we have 2% of people injecting drugs. From the new HIV infections, from 56%, we dropped to 3% among drug users. And from the overdoses deaths...
Sorry, Doctor. Sorry, that concluded our time, but I see you just have a couple more slides, so I think we all agree we'd like to see it finished, so thank you. Sorry to interrupt.
Sorry, Chair. Just to finish, next steps, we are just on the process of approving a new strategic plan. We will have next week a new government. We already presented a new plan that is based in 3 pillars: protect, care, and empower. And discussions on legalizing or regulating cannabis for non-medical purposes are already on the table. The issue that relates to safe supply has something to do with what about the other substances and regulating of other substances. Thank you, Chair, for your questions.
No, thank you so much, Doctor, for that presentation and taking the time with us today to jump across the Atlantic and spending some time with us today. So we really do appreciate that. We're going to dive into question and answers with the members here, but before we do that, if MLA Stefan can introduce himself for the record.
Hi there, MLA Jason Stefan, read to yourself. Thanks for your presentation.
Thank you.
Excellent. Thank you, MLA Stefan. We have MLA Amory up with the first question.
Hello, Dr. Goulão, and thank you very much for your presentation. I wanted to wish you a good morning, but I know that it's probably the afternoon where you are, so I appreciate you spending the time and presenting to us about this model of Portugal, which is sort of the gold standard, I think, when it comes to the type of discussion that we're having here this morning, and the types of information that we're looking to extrapolate from this committee and from the presenters. Doctor, I want to talk a little bit about the process of change when it came to Portugal's decision to move with this model to deal with contemporary addiction and drug issues. I know that the system that you described in your presentation, from what we heard in our other presentations, that this system involves or incorporates a number of different agencies and organizations that are all working together to try to accomplish a common goal, and that is namely to deal with the contemporary addiction and drug issues that all nations essentially face. I also know that from the description that you provided to us, that this system includes cooperation between the judicial system, police, organizations, and healthcare systems and whatnot to help work together and try to focus on the common goals that you described in your presentation with respect to the 5 pillars. I'm wondering if you can help us with a question that I have, and that is really with respect to police involvement, police enforcement. I want to know if you can describe to our committee what role the police play in the Portuguese system, I guess. What sort of involvement, what sort of integration do the police have with respect to the model?
Thank you, sir, for your question. The police authorities are key in dealing with people who use drugs. We articulate very closely with them our strategy in trying to bring to the presence of the Commission for the Dissuasion of Drug Addiction the target groups that we choose together, and their activity is key in providing to the health system the opportunity to interact directly with those people who use drugs. They have a quite friendly, say, attitude, but in any case, there are still, as I said, using drugs in Portugal is still forbidden, and the enforcement, without being in any way violent or respecting the rights of the people, they address and give us the opportunity to interact with those drug users and to better identify the needs that they might have, either in terms of treatment or other kind of interventions as social support or others. It's important to say that in our model, the coordination bodies are key. The responsibility for drugs policies in Portugal stands on the Minister of Health, and on his behalf, there's a national coordinator, in the case, the General Director of SICAD. They work closely with personal representatives of 11 ministers in a almost daily basis, so we can establish and define priorities to act.
Sorry, next up we have Emily Milliken.
Thank you very much, and thank you very much, Chair and Dr. Goulão. I think that I think I'm actually going to build a little bit off of what MLA Amory mentioned. He sort of got into a little bit with regards to police and the idea of illegality of drugs in Portugal and decriminalization. I just want to be clear that a lot of people, when I talk to people here in Canada and we talk about Portugal and decriminalization, a lot of people just assume that it means that people in Portugal are essentially free to use for personal use drugs. A lot of people just take that as sort of what it means. I think that it's fair to say that clearly in Portugal drugs are illegal and prohibited. I think that, again, the word that I think that you used was forbidden. Given that, that means that if a police officer does catch somebody who is in possession of drugs, no matter the amount, that individual can be arrested and brought to the police station. Is that correct? Yes? Thank you, sir. Can you then do me a favor and describe the process of what happens to that individual as they then go to the police station? What's the process once they go through those doors?
Okay, thank you. Well, the person is caught by the police authorities using drugs or in possession of drugs is conducted to the police station where the substance or substances are apprehended. They are weighted by the officials, and if the amount is superior to the one that is calculated on the basis of personal use for 10 days, there's a table with different amounts for different substances. If the person has more than that, he undergoes criminal procedures as before. He's sent for the criminal justice system as before, up to the trial of the judicial system to produce evidence that he or she is trafficking or dealing drugs or in any way. But if the person has less than that amount of substances, is just intimated by the police, just gets a piece of paper to intimate the person to present at the Commission for Dissuasion of Drug Addiction, which is an administrative body under the Ministry of Health. And he must present in a 3 days delay. At the same time, the police officer sends a copy of that intimation to the Commission, so the Commission already knows that this citizen is going to show up. If he doesn't, there's a communication to the police authorities again saying, oh, this person did not appear at the Commission. Okay. This is the process to come there.
No, I have an unrelated question, so maybe I'll just...
Okay. Next up, we have MLA Stefan.
Great. So I just want to learn a little bit more about the Commission for the Dissuasion of Drug Addiction. We don't have anything like that here in Canada. So I understand that under Portugal's system, just correct me if I'm wrong, if you're arrested for possession of drugs, but you possess an amount that is low, that would be for personal use, as you've described it, then they are required to attend this commission. Is that correct?
Yes, it is.
Okay. And just a quick question. Is this commission unique to any other jurisdiction that you're aware of?
No, those commissions, and we have one of those bodies on each district capital. We have 18 in Portugal, plus one in Açores and another one in Madeira. And those commissions were created specifically for this endeavor. They are composed of 3 members. They act under the Ministry of Health. The three members are typically jurists, someone who knows about laws, a psychologist, and a social worker. And they have a team of support, a technical team, that interviews, collects an history of consumption, a history of social and family history. They may use some diagnostic tools in order to score if there is an addiction or just an occasional recreational use of substances. So they produce a report that is presented to the commission, to the members of the commission, that interviews the indiciated. This is a quite distressed environment, I'd say. It's not a court, it's not a formal audition, I'd say. And the main goal for that audition is to identify what kind of needs does this person have. Is he or she addicted, in need of treatment? It is discussed, would you like to undergo a treatment? Have you never tried to approach a treatment facility? Yes, I thought about that, but it's so difficult, so complicated. Do you think so? Would you like to start tomorrow? We have a phone call and have an appointment for you tomorrow, the day after tomorrow. And I would say that most of them accept to have that appointment. I'm not saying they are going to be successful the first time, but at least they have a face, they know, they have a referral that is active. And from now, it's easier to undergo and to search for a treatment if they need it.
That sounds excellent. Thanks.
Most of people, hopefully, are not addicted. The vast majority of people who is presented to those commissions are not addicted people, are just occasional recreational users. But even then, the commission tries to identify any kind of factor that, along with drug use, may be present in the citizen's life and may benefit of some kind of support, some kind of help, either from the social or health services to whom he or she may be referred at this point. And this is the same mechanism, I'd say. Okay, I have no problems with drugs. I smoke a joint with my friends on weekends. But in any case, my parents are divorcing. My father just lost his job. Myself, I am facing some psychological difficulties. I am imbalanced with my gender choices or whatever. And I may invite, would you like to discuss it with a psychologist? Would you like to have an appointment with a social worker that may help your family? So the aim is to interrupt a career that may lead to a more problematic use later on. I don't know.
Perfect. Thank you for that response. Next up, we have MLA Allard.
Yes, thank you, Chair, and thank you, Dr. Goulão. Your last comments were the perfect segue into where my head was going. In your presentation, you talked about, you had a slide that had about 150,000, maybe 148,000 people, and of that 148,000, just over 82,000 were identified to be non-problematic users, and about 15,000 problematic. I'm just curious, especially given your last comment, is there a statistic showing how many of the non-problematic are repeat back into the commission? And is there a trend to become problematic over time?
Thank you for your question. Yes, there are statistics. I don't know them by heart, but there's most of the people of the non-problematic drug users come back in the next year at least. And when in the second time they appear at the commission, the use of administrative sanctions may start.
That's helpful. That's helpful. And I want, that leads me to my next question. I wanted to know, you explained the general process of the commission. What I wanted to know is, can you describe for our committee today the type of sanctions that can be rendered if a person refuses to participate in the commission process?
Well, the person may refuse, may do not appear at the commission as scheduled. In that case, the commission refers the absence of the person to the police authorities again, and they may prosecute the person for disobedience. It is not for drug use, but for disobeying to an order. So they may incur in other kind of penalties not related and not applied by the commission.
Thank you.
Next we have Emily Yao.
Thank you so much, Chair. And Dr. Goulão, thank you so much for taking the time to speak with us. We greatly appreciate your time, experience, and expertise in this matter. My question to you, sir, is we know that Portugal built a significant recovery-oriented system of care for people with addiction so that they can stop using drugs and begin to heal. Portugal's system includes therapeutic communities, opioid agonist therapy, and other forms of counseling and treatment. In your opinion, would the Portuguese model work without this commitment to a recovery-oriented system of care? Example, here they seem to, in British Columbia, they seem to just offer the prescriptions and the opioids, but not necessarily holding the people accountable to when they accept these drugs.
Well, I would say that one of the main characteristics of our system is the broad range of options that are offered to people who use drugs and to their therapists as well. So we have a wide range of models of therapeutic communities, for instance, that work under different models. And we have the capacity to address the person according with the main difficulties that he or she faces in their lives. We are dealing with a chronic relapsing disease, so it's possible that the first attempt, the first system to be used is not the most adequate to that person. So we have the opportunity, if things don't work on the first attempt, we have the opportunity to try again, and we never give up of that person in any case.
Thank you. Just to clarify, so in your opinion, if Portugal were to have simply decriminalized drugs without having the recovery-oriented system of care that Portugal provides, do you think your nation's strategy in combating opioid use would be as successful as it is today?
No, sir. I don't believe we would have the success. Success comes exactly of this integrated set of responses. Decriminalization has had its virtues. The most important, in my view, is turning everything much more coherent with the idea that we are dealing with a health condition rather than a criminal one. So that's why decriminalization is important, and also the practical way that we have put it in place that allows us to consider those commissions I described as a tool for prevention, for indicated prevention. But it's important to have a referral network for which we can refer people, and that easily can find responses if they wish to treat themselves or to rebalance their lives by means of harm reduction facilities, for instance.
Emily Rosen.
Thank you so much, Doctor, for joining us today. Technology is amazing. You're over in Portugal and we are all here in real time. So I'm so grateful that we were able to connect because Portugal is a world-renowned success story. So the one question that I do have will sort of go along the same avenue that Member Yao was on. I'm just wondering if yourself or your government has any data anywhere or that you're aware of any data to suggest that decriminalization of drugs on its own without any recovery-oriented supports around it has any positive effect on reducing overdoses.
Thank you for your question. It's impossible to establish decriminalization as an independent variable. We cannot say we decriminalized, we got those results. It's the whole system, the complete package that led us to this improvement in situation. Impossible to say it came from decriminalization. What we feel is that altogether, those different components of our policy worked and are still working quite well nowadays. But as an independent variable, it's not possible to establish. We tried, but we could not find.
Okay. Thank you.
Excellent. Emily, did you have a quick follow-up?
No, I am good. I think between myself and Member Yao, we covered most of the questions. I think both of us probably had around decriminalization, so thank you.
Okay. I know we just ran out of time, but I had one more question on the list. Did Emily Allard, did you want to get that in now?
If I may, Chair. And again, thank you, Dr. Goulão, for being here. I have actually one follow-up from my previous and then one additional question. So I had asked you about penalties for those at the commission or consequences for those sanctions. But I'm wondering what happens to those that are identified as problematic users and they refuse to participate in treatment. What kind of sanctions do they experience?
Up to them. We have no compulsory treatment. We invite, we try to persuade them to accept the treatment, but they are free to refuse. They may say, no, I am not interested. Okay, go in peace. Please do not come back to this commission, let's say in the next 6 months. Otherwise, I will have to apply you a penalty as well as to the non-addicted person that we spoke before. In the first contact, usually there's no penalty, time to think, but if they wish and if they reconsider, they may come and ask to have to be addressed for treatment facility meanwhile.
And with respect to the dissuasion process, that if somebody is a repeat offender and they're identified as problematic, those penalties can escalate and become quite severe, no?
Yes, they may. But most of the penalties are sought to increment the follow-up, to permit the follow-up of the person. For instance, one of the penalties, let's imagine someone who is HIV positive and is missing his consultations at the hospital, the follow-up of one of the penalties of the commission can be, okay, you must retake your consultations and bring me the evidence, a piece of paper showing that you are attending your consultations again. You must come here every 2 months, bringing the evidence that you are seeing your doctor for this endeavor. And this is essential, and this is something that may be used. That's why I said the vast list of penalties that may be applied may be adapted to the lifestyle and to the personal conditions of each of the citizens.
Thank you so much, and I know we're really pushing it for time, so this is my last question with your indulgence, Chair. Is that okay?
Have at her.
Okay. Activists in Canada are advocating for the government to provide prescription opioids and stimulants to those that want to use drugs free of charge and without a prescription in the form of take-home kits. Is this something that Portugal ever considered or would ever consider?
No, we have not considered yet, but I completely understand that this is a discussion going on. I think it's not easy, according with the international environment and all the treaties and everything that we have agreed upon at the international level. But anyway, the treaties are not written in stone, and those treaties consider that the use for non-medical use of such and such substances is forbidden. Nowhere it says it must be criminalized, but it's forbidden. But how to consider that prescribing substances to those who are dependent, who have a substance abuse disorder, prescribing them the substance they are dependent on, is it a medical use for substances or not? This is a question that I think deserves to be considered.
Excellent.
Mr. Chair, with your indulgence.
Yes, sorry. If it's the will of the committee, allow one more question, and it seems to be we will allow one more question if we can keep it tight because we do have a presenter waiting.
Yes, absolutely. Thank you. I should have started my last question, actually, Dr. Goulão, with just a couple comments. I know from your background you're a doctor, and I know that in 1997 you became the national director of the Network of Drug Treatment Centers in Portugal. That was 97, and then your presentation with regards to the new strategy, the integrated model approach, kind of brought us to 1999, so a couple of years in. So you were part and parcel with regards to creating the strategy in Portugal, which I think Member Amory might have called it the gold standard. It's definitely, I would agree with him, and it's a model of best practices, or at least people view it that way almost universally. So. With that, taking us back to that so again, thank you very much. It's my honor to have the opportunity. That's why I had to jump in for another question, so thank you to the chair. So going back to the original kind of, when you were breaking down the original new strategy, 1999 and moving forward, I'm not sure exactly what slide it was, but you mentioned two of the sort of pillars, or I'm not sure that was the word, but two of the main focuses was demand reduction, if I remember correctly, and then supply reduction. I sometimes ask the really, really obvious question, why? So my question might be too obvious sometimes, but here it is. Why supply reduction? What's the point? What was your goal with regards to supply reduction?
Was to reduce the availability of substances circulating on the market. So. I don't know. There are some historical reasons for in Portugal that we had an explosion in drug use very sudden after our democratic revolution back in '74. Prior to that, and during the Salazar regime, drugs were not an issue in our country. But after the revolution, there was an explosion, mostly related to the return of soldiers and settlers from our ancient colonies. And suddenly, it was almost impossible to find a Portuguese family that had no problems related to drugs. In the first moment, there was a sudden availability of cannabis all over the country, brought back from the colonies and distributed freely for free for relatives and family and so on. But shortly after, some branches of international organizations introduced in our market all the other substances. Suddenly we had everything, plenty of cannabis, but heroin, cocaine, LSD, you name it. And one of the concerns was the attempt to avoid that those branches installed in Portugal and became solid and completely established, mostly dealing also or providing the access to drugs to other parts of Europe. We are very exposed in terms of coast and the possibility to enter the country. So one of the concerns was exactly to try to avoid those organizations to consolidate in our country. And in fact, that if after decriminalization, since the police authorities got somehow free of all the tasks related to mere users, they could concentrate their efforts and their means, their capacity in big criminal organizations instead of dealing only with the mere users or street traffickers. So, and by the end of the year nowadays, instead of seizing grams or kilos at street level, they seize tons in open sea and big shipments in containers. Of course, they had to change their way of acting. They improved a lot the cooperation with the international counterparts, but nowadays they are much more efficient than before in countering the bulk trafficking.
Excellent. Thank you so much, Doctor, for joining us here today and taking that much extra time with us to indulge our questions. We certainly appreciate your efforts and your presentation. So wish you a good day, and again, thank you.